Thank you and good morning. It was a beautiful talk indeed. And I'm going to talk, my name is Orna AIZENSTEIN. I'm a neuroradiologist from the Sourasky Medical Center. And I'm going to pass this little talk in collaboration with a good friend of mine, Professor Daphne Ben-Beshat, who's the vice chairman of the Segal Center for Brain Function and Advanced Brain Imaging. And this is how it's going to happen. In the first few slides, I'm going to give you a short introduction, and later on pitch on some of the problems that we have encountered in the last few years dealing with the imaging of the neuroncological patient. I'm meaning primary brain tumors, mostly anaplastic astrocytoma and glioblastoma. And Daphne is going to give you later a possible solution and introduce some of the articles that we have published in the recent years. So, imaging tools are integrated into all aspects of managing a neuro-oncologic patient today. The diagnosis, the grading of brain tumor, surgical planning, intraoperative navigation, also to monitor and assess treatment response with patient prognosis, and to understand the effect of treatment on the patient's brain. Nowadays, the imaging relies not only on the morphological analysis of the brain, but also we have rely heavily on the physiological imaging in addition to high-resolution structural imaging. And this is for the residents among you. This is the basic protocol that we usually use in Israel for imaging the neuro-oncological patient. It includes the FLAIR, T2, DWI, SWI, pre- and post-gadolinium, and some of us use FLAIR post-contrast. Perfusion is used in most cases. MRS is reserved for special occasions. For example, if we need to differentiate between progression and pseudoprogression. Prognosis of glioblastoma patient is usually ominous. Individuals surviving more than 5 years after treatment are considered long-term survivors. Rarely selected glioblastoma patients may survive 10 years or longer. Long-term survivors are more likely to be younger patients and those who have undergone a complete surgical resection. But nowadays, we consider several molecular signatures to predict favorable patient response to treatment. And this means the chromosomal arm-level events, including loss of heterogeneity at 1p19q, silencing of MGMT through methylation, and the presence of IDH1 and 2 mutations. So, this is another slide for the residents. Most of us do not sit regularly in the neuro-oncological meetings, and it's important to know the name of the therapeutic agents people receive, because the interpretation of the MRI scan can be quite different if you know what the patient has been receiving before. Many of the patients go through surgery, followed by radiation and chemo. Temozolomide is a concurrent with radiation, and then monthly for 6 months after the radiation. Sometimes we see Gliadel, which is a cytotoxic therapeutic agent that is inserted locally into the post-surgical cavity. And when you look at the T1 pictures, you see small hyperintense dots inside the post-surgical cavity. And there's Avastin, which is an angiogenesis inhibitor. I would like to mention here that this specific therapeutic agent also reduces peritumoral edema. And sometimes we give it instead of steroids if you want to reduce the edema. Under investigation, we have the immunotherapies, meaning include checkpoint inhibitors, meaning Keytruda, nivolumab, and also Yervoy. But we do see them sometimes because people do receive them here in Israel and in other places. And we have gene therapy, vaccines, peptide, and treating cell-based radiolabeled drugs and antibodies, and also CAR-T, which is an antigen receptor T-cell therapy. So what are the challenges we faced? So the first was the inability to show the full extent of a tumor in conventional MRI sequences. Then the imaging association with genetic mutation, inability to differentiate neoplastic tissue from non-neoplastic treatment-related changes after surgery, radiotherapy, chemotherapy, and immunotherapy for conventional MRI, the early prediction of prognosis, and defined progression based on quantitative MRI parameters. So let's go with the full extent of a tumor. As we know, when you see metastasis, you see a small or a large enhancing focus, and what the hyperintense around it usually represents edema. This is not the case in primary brain tumors, mainly glioma, and when you look at that, you see some hyperintense signal. Part of it represents edema, but part of it represents the infiltrative tumor. And this is important, especially in special locations. For example, I'll give you some of what we see in these meetings. If the hyperintensity include a part of the corpus callosum, and we think it's edema, the patient will get a different management than if we think it's a tumor. So this is just to show some pictures, and here we see the focus of enhancement here with the hyperintense signal around it. This represents pathogenic edema. This is a metastasis. In another case, hyperintense signal, you see it centered in the corpus callosum without a component of enhancement, and as you go by, you see it spread to almost to the whole left hemisphere with no enhancement, and this was an anaplastic astrocytoma. Biology and then genetics, the WHO classification system continued to integrate genetic profile with tumor definition and histological variants. But nowadays there's a lot of research going on trying to connect the genetic features of a tumor with a lot of factors, other factors such as diagnostic, prognostic, therapeutic, and also the imaging implication. And this is just a table I took from the literature that's trying to relate the genetic features of tumors to what we see radiologically. And I just want to point out the MGMT promoter methylation, that the residents can see that it's connected to pseudoprogression more commonly. So it's good to know that. And then the inability to differentiate neoplastic tissue from non-neoplastic treatment-related changes. Contrast enhancement, significant local breakdown of blood-brain barrier is the key feature seen in many brain tumors. With glioma, the contrast enhancement is generally considered to be associated with high-grade tumor, but there are exceptions. For example, polycystic astrocytoma, which is a relatively benign tumor that enhances vividly in some places. On the other hand, we see some high-grade glioma without enhancement at all, like the one that we've seen before. This is a classical case. This is a case of a patient that was diagnosed in 2005. He had minor operation, but the mass was not removed, obviously because of its location, and he decided not to get chemotherapy at all. So you see the mass in here, which is hyper intense, no enhancement. After a while it grows, classically. A year later, still growing. But here it developed vivid enhancement that was correlated to the breakdown of the BBB, and slowly afterwards he deteriorated. I would like to mention the RANO criteria that we use in order to assess if a patient has responded to treatment or progressed. Before the McDonald criteria, people used to relate the RANO criteria, people used to relate to the McDonald's criteria. And the McDonald's criteria are dealing only with the enhancing component of the tumor. But as we see, the hyperintense component of the tumor is quite important, and important to notice if you want to know if the patient has progressed or not. So the RANO criteria relate not only to the enhancing component, but also to the hyperintensity. If you take a good look at this criteria, you'll see that the enhancing component is getting us a very accurate assessment by percentage. And the hyperintensity is assessed only by eyeballing, more or less, but not in accurate measurements. So these assessment criteria provide a framework for evaluation, but does not account for some of the subtleties that we see in the post-treatment brain. For example, pseudo-response or pseudo-progression. And what is pseudo-response? This is a marked decrease in contrast enhancement following treatment with Avastin, an angiogenic agent used in recurrent glioblastoma. And this is a picture for one of the first articles that was published about it. We see here the enhancement component in here, and here is the hyperintensity. And after the treatment, there is no enhancement at all, but the hyperintensity continued to grow. So this is pseudo-response. And then the pseudo-progression, which is an increase in contrast-enhancing tumor and T2 flare signal abnormalities, most often associated with concurrent radiotherapy and temozolomide. And this is very common. You see it in almost 20% of the patient that has been treated. And it may be seen more frequently in tumors with MGMT promoter methylation, as we mentioned before. So again, a picture from one of the old articles when it was published first. Here the patient had chemotherapy and radiation. Here we see some hyperintense signal, more enhancement and hyperintensity. This is when the biopsy was taken, and then reduction in the enhancement and hyperintensity, and this was pseudoprogression. I would like to mention here, mostly for the sake of the residents, but all of us, that here in Israel, when we do perfusion, we usually look at the perfusion maps and don't go to the device and look at the curves and process it. So the perfusion can be achieved by several methods, by DSC, by DCE, and also by ASL. But in Israel, what you usually see, the RCBV maps that are achieved by the DSC method. And this method is really susceptible to artifacts, sensitive to susceptibility. So you see a lot of artifacts there in proximity to bone, to air, and also to blood products. And this is a case I want to show you that we had just a few days ago. Here we see some enhancing component near to the post-surgical cavity. And if you take eyeballing at the map, you see nothing is really going around there. So we thought it might be pseudoprogression. But if you look at the DCE and the processing, there is a lot going on in this region. And this was actually the progression of a tumor. So differentiating of pseudoprogression from progression in patients who receive immunotherapy is an important issue today. The goal is to harness the patient's immune system to fight cancer, and therefore inflammation in a tumor bed is expected more than with cytotoxic chemotherapy. Also, follow-up of the patient should be done in other time schedules than what we do now. And I wanted you to see this case. This is a case of a patient that received T-cell therapy in the USA a few months back. And he responded quite well. He had this small enhancing component with a lot of what looked morphologically like an edema. And later on, a few months later, he deteriorated and had progression, just to see how it looks like. Early prediction of progression and defining progression based on quantitative MR parameters. So this is a patient that had glioblastoma in here. This is the enhancing component and the hyperintensity. And this was taken out by surgery completely. But if you look a bit up in the parietal region, we see some hyperintensity here that is in the parietal region and also in the cingulum. No enhancement. After a while, it will seem to be stable, even reduced. Later, we can see some small dots of enhancement. I don't know if you can see it in here, but it was not called progression because it does not answer the progression criteria. And later on, we see a lot of hyperintensity and enhancement in here, and this patient progressed. So I wonder, and that's one of the questions we asked ourselves, what if at this stage, or maybe in this stage, we can tell the neurosurgeons and the neuroncologists that this patient is about to progress? If the decision-making we would do of this patient will be different. And that was one of our aims. And Daphne, please.
Thank you. So coming back to the challenges, we've been working for more than a decade on building a method to really to answer all those challenges. So the last and the final method that we suggest, what we call segmented RANO, because we were based on RANO, but we said, okay, it's not enough. There are questions about pseudo-progression, pseudo-response. So how we can just answer those questions? And the method was based on three main principles. One, we said we don't rely on one contrast, so we'll take multiparametric. Since we know that especially in malignant glioma, they relays on the angiogenesis. So we look a lot of parameters of the on vascular imaging and specifically on dynamic contrast-enhancement, as Dr. AIZENSTEIN said, because it's less susceptible to susceptibility artifact, it has high spatial resolution, and also give a model for permeability, and I will just present one slide on it later. So relying a method on multi-parameters assume and is providing us a more accurate answer for tissue classification. The other thing, since we are dealing with multi-parameters, so eyeballing on a voxel base on 10 or 15 parameters is almost impossible. That's why we need to use automatic classification, machine learning methods for all this data sorting, and it's a whole field of machine learning and of image reconstruction, and this is one of the computational aspect. And the last aspect is relating to both enhancing and non-enhancing lesion, because malignant glioma known to infiltrate, so it's not enough just to look at the enhancing lesion, but also to classify the non-enhancing lesion. So talking about multi-parameter, as I said, we use a lot. We use the conventional imaging, T2 FLAIR, T1, SWI. We use diffusion, and we use a lot of the vascular parameters. Histology and MRS usually used for us not for classification but for validation of the results. In cases we have biopsies, so we do try to look if we said that this is a necrotic area, so, or if this is infiltrative tumor cells, so we look for correlation with histology. And in cases that they don't take biopsy, especially in the non-enhancing lesion or far from the enhancing lesion, usually they don't resect this area or do not take biopsy, so rely on MRS, which also known to give us information, especially differentiation between recurrent tumor or radiation or treatment effects. So the basic hypothesis behind is that different MR parameters represent different physiological or microstructural properties of the tissue. So we don't just take any parameter, mostly what we know that histological see. If they do see proliferation of blood vessels, so we do expect to see increase in the cerebral blood volume or the volume of the plasma. If there is increase in the large cells, cell size, so we look for diffusion. So we put all parameters, but usually later on the machine learning algorithm just choose the best parameters that give the best classification results. So just one slide on dynamic contrast, because we started now to shift from dynamic susceptibility contrast to dynamic contrast enhanced, which is a T1 based perfusion imaging. This method have the main advantages over DC, that it's less susceptible to susceptibility artifacts, or in case of any sign for after tumor resection, so we don't get this artifact. It has better spatial resolution, and it gives a model that provides more parameters than DSC, especially all the permeability, quantitative permeability parameters like K-trans and K-ep and the volume of the extravascular extracellular space. So this method we developed, and we have our own method for analyzing this, taking into consideration some artifacts or some problem in this acquisition. Talking about automatic classification, and just a brief view, probably you heard a lot of conference. There is a lot of approach how to use this method. So you can, in general, you look at the group level, but we always need to have answer on the subject level. We cannot just say these two groups are different, but also when a new patient is come, we need to provide a subject-based classification. We want to make it on a voxel-based, and there is different approach whether you use supervised or unsupervised, but these things that there's the approach of the level. There is a lot of method for machine learning. Probably you heard the buzzword that is coming now in every conference, deep learning, but it's just on the level between simple machine learning classifier going to radiomics, which takes more features. Some of them are not really intuitive, like what is the energy of the voxel or the patch that we use. So it's something that we cannot explain why this parameter we're choosing. And of course, deep learning, which is a total black box that just the algorithm decide how to classify patients. But in general, we just use what is best. Simple model always are recommended because they have less, if they are good enough. Otherwise, we go to others. So we choose the best method, not just going to the most recent one. And when we talk about relating to both enhancing and non-enhancing and all, and inability to differentiate on all this, so what we propose after really many years that we tackle each challenge alone, a method that we call segmented RANO, because this for us gives us a best answer to all this challenge. So what we in general do, we take the enhancing lesion and then classify it either to active tumor or treatment-related changes or necrosis, and we identify the non-enhancing lesion and also classify it into infiltrative tumor and to vasogenic edema. And we do this based on what I said, multiparametric approach using machine learning algorithm, and finally we get these four classes. The tumor are the red and orange, the tumor are the red and blue, then red and orange the tumor, but the enhancing is red and blue. And the non-enhancing, again, the orange is the tumoral and the green is the non-tumoral. So just to show you some example, This is a patient with metastasis, with breast cancer metastasis, and as you see, the enhancing was of course a tumoral, but the edema around, of course, as expected, is a non-tumoral component. But when we come to patients with glioblastoma, always we get a mixed result. They're never just pure vasogenic, and that's why it's important not to classify the entire lesion, but really to go by voxel-based classification, and then we can see that some areas are more vasogenic. Here, when it penetrates through the corpus callosum, it's more tumoral component. Distance from the enhancing is more vasogenic, and then we can estimate and see how much of the non-enhancing tumor is vasogenic and some vasogenic-like, because of course there must be few cells within it, and so how much of it is more infiltrative tumor. So how we validate results, and we've been working with this method for more than 5 years, and we have more than 200 cases that we analyze using this method. In case we have histopathology, of course, we try to do even a biopsy guided, so this area is more tumoral and this is more radiation necrosis or treatment effects. And of course, radiological follow-up is always something that is used for validation. If we said that this is a tumor, this area is more tumoral-like, and then 2 months we saw that it increased, so it is another validation. And as I say, spectroscopy, in tumoral component, we always see increase in the choline and reduce in the N-acetyl aspartate, and in area which are more non-tumoral, if it's necrotic, so there's a depletion of all metabolite. If it's just vasogenic-like, so we do see a normal ratio between choline and creatine, and still normal or some level of N-acetyl aspartate. So all this is just to validate, because when we said something, it's just nice color, but how we can be sure that we are right. So now more and more we get more confidence of our results. So this is a case when Dr. Eisenstein should talk about early prediction, but this was done after. So this is a patient come with a many enhancing lesion, and if this patient is prone maybe to a resection or focal radiation, so how do you know which of this lesion is really a malignant tumor or just any radiation or treatment effects? And when we classify this patient, we see that this lesion is really tumoral, while those two are more non-treatment-related changes. And a few months later, as you can see, that this lesion really enlarged, and this one, which we diagnose as a non-tumoral component, almost diminished. So this, in case if we could have done this on time, because this was done retrospect when we developed the method, so this may aid and help neurosurgeon or neuro-oncology decide on the best treatment. Some other example for early prediction is that this patient that it has follow-up scans, and you can see here the post-contrast imaging and the flare imaging, and this is the sign of the RANO criteria diagnosis. So you can see that before scan and 1, 2, there is a progressive disease. It's diagnosed as RANO, and this time this was pre-Avastin, bevacizumab, and this is about 6 weeks later, and then 2 months later, and you can see that based on RANO criteria, at this time point, it's considered stable disease because there is a reduction in the enhancing tumor, almost a little bit reduction in the flare lesion. Still, the diagnosis is stable disease and not partial response, because the percentage of changes in the volume required to be more than 25% in order to be diagnosed as partial response. But 2 months later, there was a progressive disease. But if we look at the classification results, so again, between scan 1 to 2, you can see progressive disease. But also between scan 2 and 3, what you see is that all the non-enhancing, non-tumoral component become infiltrative tumor. So if we look at the quality, not just on the volume of those, and so we see that this is, if you can see the orange path, between scan 2 to 3, it's hugely increased the number of infiltrative tumor, and this could be preceding RANO criteria in about 2 months. How do you find progression based on quantitative MRI? So not just classification, but if we sit once a week on patient, and then both the radiologist and the neuro-oncologist, and okay, you said that there is increase in the blood volume. Is it significant? And there are criteria, RANO criteria, defined criteria for changes in volume of the lesion, but not in the values of VP. So what we try to say, it's not just looking at the mean values, but let's see the distribution, let's see it histogram. And we develop a criteria called EMD, which is some mathematical transformation between histogram to see that if we are looking at the normal appearing white matter, longitudinal between scan, we don't want to see any changes. But when we look, for example, in this case, if you have this same patient and we look now at the volume of the plasma, so whether there is increase in these values. So what we can do now is look at the EMD, which is a parameter to define significant longitudinal changes in the volume of the plasma. So you can, and this is just a quality assurance for us that the normal appearing white matter, grain matter shouldn't change. And then you can see that there is increase in the volume of the plasma within the enhancing lesion and the non-enhancing lesion, and threshold value of about 3 or 4 EMD considered to be significant. And now we can follow up many patients, and we can see that for some patients there is significant increase in the volume of the plasma only in the non-enhancing lesion for one patient, both area, and one for one only in the enhancing. And this is something, again, now we check this parameter in addition to the segmented RANO, whether this can be early indication for progression, even if not the total classification change significant, and even if the volume doesn't change, but the quality of the volume of the enhancing and non-enhancing tissue. Last thing is just now trying to incorporate the association with genetic mutation, and this is a whole field called radiomics that we look at many features to identify between two groups, and this is just one example actually in low-grade glioma. And as Dr. Eisenstein talked, that there is the molecular alteration within the WHO classification, and this is just diagnosed between patients with one P90Q co-deletion with those with non-co-deletion, because we know that they have better prognosis, both better response to treatment and better prognosis. And what we take is then that we take a whole data, again, multiparametric approach, many features, like 500 and 1,000 features from the image, and we train the system. We take patients that we know their mutation, later to be used for patients that they don't have biopsy. And then we train it for two group, one with co-deletion of the one P90Q and the other without, and then we get different fingerprinting. So we get different pattern of imaging and sensitivity and specificity of about 83 and 92 to 87%, so that we can, just based on imaging results, say what is the genetic mutation behind this tumor. And this is something that should be also incorporated within the model, because if we know genetic, it's always expected to improve our classification. So just to summarize, if we take all this together, the way we work now and try to improve the radiological reading based on conventional imaging is to give a report. So it's still under, sorry, it's in Hebrew, but we work in Israel. But what we do take is that if we have one subject, first we mark, because just the shift from eyeballing to quantitative, or RANO, which is just a cross to check the volume. So we do really volume segmentation, both of the enhancing and non-enhancing lesion. We can compare it to previous examination and said how much it's enlarged. So this is also can be used for RANO. This, for example, increased with 59%, so it's above RANO, considered to be progression. And we give the last slide with the segmentation and the volume of each one of the component. Again, we can compare it to previous examination. We can give a follow-up. For example, for this patient, you can see the 4 component. So for each scan time, you can see changes in the volume. For example, here, just increase in the non-enhancing and non-tumoral component. But once you start to see increase in the tumoral component, then you can see maybe it's an early sign for progression. So just to conclude, we believe that adding more information to RANO, just looking not at the volume enhancing and non-enhancing, but understanding that each component combine both tumoral and non-tumoral component should improve assessment and maybe prediction of therapy response. And of course, if you use a lot of parameter, automatic methods are necessary. We hope to have a really tool aiding to the physician in their decision, because you can't sit in front of 20 parameters and decide voxel by voxel what is the classification of this voxel. So validation, of course, is necessary because color image are nice, but we need to know that what we say is true. And so it's just another subclassification, and both adding the radiomics and providing more criteria for assessment and for progressive disease or partial response are necessary. And of course, this is a whole group work. It's not mine. I just represent it, of course, with the Dr. Eisenstein, which is not here because she's talking with me, but Dr. Debbie Blumenthal and Dr. Felix Buchstein, which are neuro-oncologists and sit with R and always direct us more with the question. And of course, with the introduction of new drugs, there are new questions because the pattern change. And of course, all the students that develop the algorithm, and thank you for your attention.